Hey, good afternoon, everybody. Welcome to BFR Tuesday. I am Ed Cara, your host. Today, we're going to talk about approaches towards tendinitis, tendinosis, and kind of how to use BFR with our exercise prescription. It's a little different with tendons, so we're going to just kind of chat through this and my approach to it. So let's see. Does anybody have any questions before I get started about anything in particular, BFR? Actually, anything, whatever you want. What you got for me? What you got? All right. So let me switch over to full screen share. And let's see, share my screen. Okay. All right, so let me reduce this. Hopefully get everything out of the way. Okay. Okay, so let's start here. Actually, let's start here. Okay, so with our tendinitis, tendinosis, typically I am going to first do isometrics with these guys. So if I'm going to reduce this, I'm going to type in here just so you can see. So let's say you have a somebody with a lateral epicondylitis comes in. What I'm going to do first is I'm going to do some sort of evaluation, of course. And I'm going to look at resisted wrist extension. I'll look at it in multiple positions. I'll also look at individual fingers. So isolation for resistance of extension of the index, the third, and the fourth finger. I like to do it in different positions. I like to do it with the elbow bent. I also like to do it with the arm extended, just trying to determine what their baseline is. Then I'm going to do my manual therapy. And for me, usually this is going to include some active release technique. And it's going to usually do some sort of dry needling. Now, I don't get too crazy with these. I've made the mistake numerous times of overdoing it on my manual therapy with lateral epicondylitis. I get super sore for really long, so I don't do that anymore. I don't crush it. I kind of get in there, I get it moving, and then I retest, and I kind of re-evaluate. I want to see how low I can get their pain levels with resisted wrist extension and resisted 2 through 4 finger extension. Okay, and then I'll do this in elbow straight, elbow bent. I'll do the same thing on my re-eval. I always like to do some sort of reevaluation after I do some sort of manual therapy to see what the benefits are. Because if there's no change, I start to think that there's a tear or there's something in there more serious. I should see at least a reduction in pain. And again, my philosophy is that manual therapy is just a means to create a window opportunity in order to do more exercise. So what I'm doing is I'm trying to create a window of opportunity with the tendinitis, tendinosis, to do more exercise, and that exercise is going to be BFR. So dry needling, and then I'll do this usually with some sort of E-stim. I use a little pointer TENS. If we're gonna do isometrics with BFR, this is what you're seeing here with the picture. I'm gonna do 50% limb occlusion pressure in the upper extremity. I'm gonna do somewhere between 1 and 2 minutes of an isometric, and then I'll take a, like a 1 minute rest between sessions, okay? So 50% limb occlusion pressure, 1 to 2 minute isometric times 3. I try not to have them exceed a 5 out of 10. If they exceed a 5 out of 10, either that load is too high or the tendon's it's too hot, and so I won't even do this. If it's above a 5 out of 10 even to start, then I might just do like a reciprocal inhibition. I might have them do some work with gripping. I might have them do something opposite of that wrist extension. So hopefully that makes sense. So that might be phase 1 of BFR with BFR. Isometrics with BFR. Okay, so everybody can see how that is. Now, this might be, this could be like 2 to 4 sessions typically. It's going to be at least a week. I'm going to do at least twice a week, because twice a week has been shown to be as effective as 5 times a week. So 2 times a week probably is what I normally will do here. I'm going to do this kind of protocol for 2 to 4 sessions. Their home exercise is going to be some sort of isometric, just probably a little bit heavier, and they're going to work up to that 2 minute range. Okay, so then what I might do next then is I'm going to cut and paste this because I'm going to need this. Copy. Now I'm going to use something called ischemic preconditioning. And ischemic preconditioning is 100% limb occlusion pressure, 5 minutes inflated, 3 minutes of rest, 5 minutes inflated, and then I'm going to deflate. And then I'm going to do exercise, and the exercises are going to be eccentrics without the cuff. So I'm going to totally take the cuff off, and I'm going to just say remove cuff, just so we're clear. And then my exercise eccentrics as heavy as they can do without going above a 5 out of 10. And they're going to do something like 20 to 30 reps. So it's going to be pretty low load. Okay, so the evaluation still is, I'm going to call this, actually, let's call this tendinitis still. Still my same evaluation. But now I'm going to do ischemic preconditioning. Okay, so this is going to be 100%. And let's so there's that. Okay, so you can see here, she's at 124. That's her 100% limb occlusion pressure. I've got that inflated. She's gonna go 5 minutes on inflation, 3 minute rest, 5 minutes inflated. And I'm gonna deflate, I'm gonna remove the cuff, and I'm gonna go right to the exercises. What ischemic preconditioning research has shown, Franz would be a really great resource for this. What he was able to see is that when you do this, it reduces the amount of tissue damage done due to the exercise that you impose. We know that eccentrics cause more muscle damage than concentrics. So I'm using the ischemic preconditioning for two reasons. Number one, to decrease pain. But number two, it will also allow for decreased damage as I'm trying to heavily load the tendon. I'm a big believer that tendons require as heavy load as possible. So I'm preconditioning the tissue for the heavy load so I don't cause more damage. And then I'm using this 5 out of 10 as a gauge because I don't want to go so high that I shove her over the cliff. I'm still using my manual therapy techniques in order to try to create that window of opportunity to do more exercise. Then I'm going to do that probably, I'm going to guess you're going to probably, again, be like 2 to 4 sessions. It just really depends on how bad that tissue is. And then I'm going to get into my concentrics, just so I can be super clear. And it's really going to be concentrics and eccentrics. So we still do our evaluation. We're still going to do our manual therapy, reevaluate afterwards. I'm going to just kind of clean this up. And now I'm going to do just my normal this would just be normal strengthening, hypertrophy. %50 limb occlusion pressure, 30 reps, 30-second rest, 15 reps, 30-second rest, 15 reps, 30-second rest, 15 reps, deflate. And that's going to be it for that. That's all you're going to need for that exercise. You're going to fatigue everything out there, and you're probably going to need to do this depending on severity. Usually I can get this done in about 4 to 6 visits. I'm going to just make this a little smaller. Okay. So if you look at my first 2 to 4 visits, let's say 4, and then we have another 4, there's 8, and then we have 6. So you're looking at your, 12 to 14 visits, something like that, which is normally what it takes to get these to fully come through. But really, I'm trying to load the tissue as heavily as I can. I find that the ischemic preconditioning helps with the pain control. And then I do those eccentrics just because it's such heavy. I can do it much heavier without the BFR, and the tendons require that to regenerate. And then I hit it with concentrics for strengthening and hypertrophy. Again, not exceeding. So this is don't exceed 5 out of 10 pain, and your 50% LOP with 30 reps. It's going to be pretty light loads. You're going to be taking them through this range of motion pretty. It's a long duration, so loads are going to be lighter, and it should be pretty safe on the tissue at that point. If they can get up there and they no longer need BFR because they can lift 65% of their 1 rep max, then you can take them after this 4 to 6 visits into their normal lifting state. But that's usually what it takes to get them through these tendinitis, tendinoses. So let me bring this back. And I'll send that out for everybody if they would like. Michelle is asking me, is your treatment to sprains similar? If it's a non-tendinous, not really. When it's non-tendinous, I just usually go after the musculature. If it's ligamentous, then personally, my own opinion, if I have like an ankle sprain, the anterior talofibular ligament is literally a third of the size of my pinky. Do I think that the whole dysfunction to an ankle is due to this little ligament? I don't think so. I think the more the problem occurs because of the lengthening on an inversion sprain of the peroneal group. You lengthen that tissue, it becomes weak. And what I need to do then is shorten that back up. And so what I'll do is I'll jump right to concentrics. I don't typically do eccentrics as much. I'll go isometric, and then I'll go to concentrics with the the musculature, and I'll just use bands. And maybe I can show that on the next one. I think I definitely have some pictures of me using the bands with an ankle sprain. But because we're not treating the tendon, we're treating the actual musculature, I'm going to do the normal 30, 15, 15, 15 protocol. And in that case, I might hit plantar flexors, inverters, everters, and dorsiflexors. So you might have 4 exercises that you need to do if they can tolerate. That would be the lower extremity. So lower extremity, you're going to be looking at 80% limb occlusion pressure, but the same 30, 15, 15, 15 rep scheme. So thanks for the question. I will share the file with you, and I will dump that in. I will also put this onto my YouTube channel as well. Any other questions for today? This was kind of a summary regarding treating tendinitis or tendinosis. All right, I will send this out as soon as I get a chance. Probably won't be till tonight or tomorrow. And that's it. Thanks for joining me. Next week, maybe I'll talk about sprains. That would be a good idea. We'll talk about sprains next week and how we can approach those using BFR as our exercise intervention. Thanks so much.